Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar. This is your concise, evidence-based update designed for busy clinicians with a focus on what new data actually change and what should still make us pause. This week, we cover three very different but clinically connected topics. First, a large real-world study examining whether angiotensin-converting enzyme inhibitors are associated with improved survival in idiopathic pulmonary fibrosis. Second, new population-based data on the safety of inhaled corticosteroids and long-acting beta agonists during pregnancy, including a signal around high-dose therapy. And finally, a physiology-driven review that reframes how we think about PEEP well beyond oxygenation, linking lung mechanics, hemodynamics, and end organ perfusion. As always, this is an educational summary, not a substitute for clinical judgment. Let's get into it. We begin with idiopathic pulmonary fibrosis, a disease where comorbidities often shape outcomes as much as the fibrosis itself. Published in Chest in January 2026, this study examined whether angiotensin-converting enzyme inhibitor use is associated with reduced all-cause mortality in patients with idiopathic pulmonary fibrosis, and whether any observed association is specific to IPF rather than reflective of general cardiovascular risk modification. The investigators conducted a large retrospective cohort study using linked UK electronic health record data, including primary care records, hospital admissions, and national death registries. They identified 3,579 patients with IPF and matched them one-to-one with 3,579 patients with COPD based on age, sex, and smoking history, creating a disease comparator cohort. Among patients with IPF, 1,328, about 37%, were ACE inhibitor users. As expected, these patients carried a higher burden of cardiovascular comorbidities, including hypertension, heart failure, and chronic kidney disease. Importantly, this imbalance would typically bias toward worse outcomes rather than benefit. In unadjusted analyses, ACE inhibitor use was not associated with improved survival. However, after multivariable adjustment for age, sex, BMI, smoking status, socioeconomic deprivation, diabetes, chronic kidney disease, pulmonary hypertension, and cardiovascular comorbidities, ACE inhibitor use was independently associated with reduced all-cause mortality. The adjusted hazard ratio was 0.82, with a 95% confidence interval from 0.75 to 0.91, representing an 18% relative reduction in mortality. This association was not observed in the matched COPD cohort. In patients with COPD, ACE inhibitor use was not associated with improved survival, with a hazard ratio of 1.09 and confidence intervals crossing unity. This disease specificity strengthens the signal and argues against a purely confounded cardiovascular explanation. That said, this study does not demonstrate causality. Competing risk analyses did not show a significant reduction in respiratory-related deaths, suggesting that the survival benefit may not be driven solely by fibrosis progression. From a mechanistic standpoint, the findings remain biologically plausible. The renin-angiotensin system contributes to fibrogenesis via angiotensin II-mediated activation of profibrotic pathways, and ACE inhibition may attenuate pulmonary vascular remodeling and right ventricular afterload. However, these hypotheses remain unproven in prospective trials. The key takeaway is not that ACE inhibitors should be prescribed for IPF, but that they should not be discontinued reflexively when indicated for cardiovascular disease. Whether ACE inhibitors deserve prospective evaluation as adjunctive therapy in IPF is an open and now better supported question. This balance between benefit, risk, and indication carries directly into our next study. If the first study asks whether common cardiovascular medications may influence outcomes in chronic lung disease, the second addresses a more delicate question: How safe are cornerstone respiratory therapies during pregnancy? Published in Respirology, this population-based retrospective cohort study evaluated the association between inhaled corticosteroids, ICS dose intensity, and long-acting beta-agonist use during pregnancy and adverse fetal outcomes among women with asthma. Using linked Taiwanese national health databases, the investigators identified 4,538 pregnant women aged 18 to 49 with asthma who were experiencing their first delivery. Advanced adjustment techniques, including propensity score matching and inverse probability of treatment weighting, were used to account for asthma severity, comorbidities, concomitant medications, and sociodemographic factors. After adjustment, neither ICS use nor LABA use was significantly associated with low birth weight, small for gestational age, or preterm birth. For example, the adjusted odds ratio for low birth weight with ICS use was 1.12, with a 95% confidence interval from 0.82 to 1.52. Similar neutral findings were observed for small for gestational age and preterm birth. However, a signal emerged when examining dose intensity. Among women exposed to ICS, those receiving high-dose therapy, defined as greater than 800 micrograms per day of budesonide equivalent, had a significantly increased risk of congenital anomalies diagnosed within 1 year of birth. The adjusted odds ratio was 3.87, with a wide confidence interval from 1.29 to 11.60. This finding warrants caution. Only 37 women received high-dose ICS, and after waiting, the effective sample size was even smaller. The absolute number of congenital anomalies was low, and the study did not distinguish between minor and major anomalies or provide trimester-specific exposure data. Sensitivity analyses suggested possible associations with LABA exposure under stricter definitions, but these findings were inconsistent and near the threshold of statistical significance. Taken together, the dominant message remains one of reassurance. Controller therapy with ICS and LABA during pregnancy was not associated with adverse fetal growth outcomes, and maintaining asthma control remains critical. The signal with high-dose ICS should prompt reassessment of adherence, inhaler technique, triggers, and comorbidities rather than avoidance of controller therapy. The same principle, precision over reflex, applies equally in the ICU, where common interventions are often simplified to single outcomes. That brings us to our final article. We'll close this week in the ICU with a study that is less about new data and more about getting the fundamentals right. Published in Intensive Care Medicine, this narrative review reframes positive end expiratory pressure not as an oxygenation setting, but as a global intrathoracic intervention that simultaneously affects lung mechanics, pulmonary vascular resistance, cardiac preload and afterload, and ultimately end organ perfusion. To understand PEEP, the authors start with first principles. In ARDS, lung injury is heterogeneous. Dependent regions collapse under gravity and lung weight, while non-dependent regions remain aerated. The functional lung, the so-called baby lung, is therefore small and vulnerable. When PEEP is applied, end expiratory lung volume increases by recruiting collapsed alveoli and preventing airway closure. This reduces cyclic opening and closing and distributes tidal volume across a larger lung surface. However, recruitment and overdistension always occur together. A single PEEP level can reopen dependent lung units while simultaneously overinflating already aerated regions. This is why improvements in oxygenation or compliance alone cannot be assumed to reflect lung protection. They represent the net effect of two opposing regional processes. A core teaching point in this review is the relationship between PEEP and pulmonary vascular resistance. Both atelectasis and overdistension increase right ventricular afterload, producing a U-shaped relationship between lung volume and pulmonary vascular resistance. When alveoli are collapsed, hypoxic vasoconstriction and compression of intraalveolar vessels raise resistance. When alveoli are overdistended, extraalveolar vessels are compressed and dead space increases, again raising resistance. The optimal PEEP level lies at the bottom of this U-shaped curve, where where recruitment improves ventilation-perfusion matching without inducing overdistension. Clinically, this explains why increasing PEEP may initially improve right ventricular function, but further increases can worsen it, particularly in patients with pulmonary hypertension or limited right ventricular reserve. The cardiovascular effects of PEEP extend beyond the pulmonary circulation. By increasing intrathoracic pressure, PEEP reduces venous return and right ventricular preload. At the same time, it lowers left ventricular afterload by reducing transmural systolic pressure. These opposing effects explain why PEEP can precipitate hypotension in preload-dependent states, yet improve cardiac output in selected patients with left ventricular failure. This dual effect is often tested conceptually. If blood pressure falls after increasing PEEP, the problem is not too much PEEP, but insufficient preload or right ventricular tolerance. Conversely, improvement in cardiac output with PEEP suggests afterload reduction is dominating. One of the most exam-relevant lessons emphasized by the authors is that oxygenation is not synonymous with oxygen delivery. Increasing PEEP can improve PaO2 by reducing shunt fraction, even as cardiac output falls. In that scenario, arterial oxygen content may rise while total oxygen delivery to tissues declines. This is why PaO2 alone is an unreliable marker of benefit. From a practical standpoint, the review highlights tools that help clinicians move from empiricism to physiology. The recruitment to inflation ratio estimates lung recruitability at the bedside by comparing recruited lung compliance to baby lung compliance. Electrical impedance tomography provides regional information on collapse and overdistension, making visible what global compliance and oxygenation cannot capture. The board-level takeaway is this: PEEP is not an oxygen setting. It is a hemodynamic, pulmonary, and mechanical intervention. Its optimal level depends on recruitability, chest wall mechanics, right ventricular tolerance, and systemic perfusion. For clinicians and trainees alike, the correct question is not, does PEEP improve oxygenation, but what is PEEP doing to lung stress, right ventricular afterload, preload, and oxygen delivery? Mastering that framework is what separates safe ventilation from accidental physiology. Across three very different clinical settings, this week's studies point to the same underlying lesson. Therapies rarely act in isolation. Their effects extend beyond the target organ, and their value depends on context, dose, and patient physiology. Whether you're managing fibrosis, counseling a pregnant patient with asthma, or titrating PEEP at the bedside, nuance still matters. If you found this episode helpful, consider subscribing so you don't miss future updates. Thanks for listening. I'll see you next week.